Hi, everyone. Thanks so much for being here today. Welcome to Caltech Y's Social Activism Speaker Series. I first just want to say that if you want to be a part of the committee that organizes this speaker series and invites speakers to come talk, please contact caltechy@caltech.edu and just say you want to join. So today we are very fortunate to have Professor Irene Headen with us. Dr. Headen received her doctoral degree in epidemiology from UC Berkeley in 2015 and is now an assistant professor of Black Health in the Department of Community Health and Prevention at the Drexel Dornsife School of Public Health. She studies the structural determinants of racial disparities in adverse pregnancy outcomes. Today, she's going to talk to us about how these structural disparities are affecting the current COVID-19 pandemic. If you have any questions during the talk, please put them in the Q&A feature, but we're going to wait until the end of the talk to get to the questions, just so you know, but feel free to add a question at any point. All right, so without further ado, I'll hand it over to Dr. Headen.
All right, thanks, Eliza. And it's great to be able to talk with you all today. Let me just get my screen share going and presenter view. And I will get started. So as Eliza said, today I'm going to be talking about not only kind of the structural drivers of the pandemic and especially racial disparities in the pandemic, but especially kind of these intersections of how the emplacement of these social inequities are really kind of a driving factor in how both racial disparities and COVID-19 emerged and how they persist. And to give you just a brief overview, of course, I'm going to start with kind of the background of how we kind of start to understand the full impact of these disparities for Black populations and populations of color, and also kind of transition into how we went from a deeper understanding of how structural factors really play a role in driving these disparities. And then I'm going to present some examples of some of the work that we've been doing in Philly, which is where Drexel University is and where a lot of my work is located. And then I'm hoping this will be a great foundation for seeding a great conversation at the end about again, how structural drivers play a large role in both shaping and perpetuating these racial disparities in COVID-19. So to jump right in, it's been a long pandemic, but even at the beginning of the pandemic, back in March was when in Philadelphia, we started to see, the first cases and started to get the notice of the stay-at-home orders on a large scale basis. And at that time, it was kind of the coronavirus was being touted as kind of the great equalizer. Everyone was at the same risk of, catching and succumbing to the disease. But quickly it emerged that there were racial ethnic disparities in the coronavirus disease, so COVID-19 cases, as well as deaths from COVID-19. And these are just a few examples of, the early articles showing that even though that coronavirus was touted as the great equalizers, there were very persistent and alarming disparities that were emerging across racial ethnic groups. And this is data from the Brookings Institute from that early period, but extending on into the June period. And it's reflecting that the magnitude of these disparities, especially for Black as well as Latino populations, was actually quite substantial. If you're looking in kind of, the highest age group, the death rate, and this is deaths, although the case rates also reflect the same kind of pattern. The death rates seen in this population were substantially higher than the white death rates seen. And interestingly, Brookings kind of broke it out by age category, and these racial disparities were seen across all age categories, kind of counteracting the notion that it may be just that, different populations may have different age structures or different kind of proportions of elderly people that might be driving these disparities. One thing that was both interesting as well as alarming in these early sets of numbers as they were coming out was that if you look at the side-by-side age categories and look at the death rates for Black individuals, or Black populations compared to white populations, and hopefully you all can see my pointer here. So if we take the 65 to 74-year-old age range, we can see that the death rates for Blacks in this group were actually higher than the death rates for whites in a completely older age category. And so it was these kind of alarming first signals of not only kind of the presence, but also the magnitude of these of these racial disparities in COVID-19 that started sending out a very urgent signal about how this disease was impacting already structurally vulnerable populations. And one thing about this early data was that it was actually, these signals were important, but they were limited by fragmented information. So in the early stages of the pandemic, not all states were collecting information of cases and deaths by race ethnicity. And even among those states that were, there were a large proportion of cases that were either marked as unknown race ethnicity or other race ethnicity that were really hampering the ability to capture the full burden of COVID-19 in these populations. And so since that early portion of the pandemic, starting then and even continuing on, there's been this really robust call to collect more consistent and high quality data on race ethnicity if we're going to have kind of workable information about these disparities from which to actually leverage action and intervention. And this was led by partially by the Ibram X. Kendi's Center for Anti-Racist Research, which this is their website there, and then also by Data for Black Lives, which early in the pandemic was one of the organizations that I was affiliated with, and moving forward this call for the need for robust and consistent race ethnicity data in order to fully understand the impact and the impact of COVID-19 in racial ethnic populations in the US. And so since then, there's been, again, both the COVID-19 or the COVID racial data tracker, as well as this is the AMP site, which is the American Public Media, and Data for Black Lives, all have kind of robust platforms in which you can engage with the racial ethnicity data on COVID-19. But a recent article in NPR summarized it quite well. And it's basically showing that when we have more robust data across multiple racial ethnic groups, we still see, unfortunately, the same trends. And this chart is showing that the gray line is basically the proportion of the population that subgroup comprises. And so, of the US population, it's 12% Black. And then the red and the orange lines are the proportion of deaths and cases that population comprises of within the known, COVID-19 deaths and cases. And across racial ethnic groups, such as Black, Latino, and Native American groups, again, we see the same trends reflected, that there's a disproportionate share and a disproportionate burden of both deaths and cases within these racial ethnic groups. Another element of the call to kind of collect more robust data also allowed a more comprehensive look at these trends over time, which, as an epidemiologist, which is my training, it's important to understand how these trends are evolving and changing over time if we're really going to understand the factors or start to unpack and target and intervene on the factors driving these disparities. And so again, this is data from the COVID tracking project, as presented in a recent NPR article that's cited here at the bottom. But we can see that over time, among Black populations, both the death rates and the case rates comprise of a disproportionate share of the population, with actually death rates comprising having a higher disproportionate burden on this population compared to case rates. And then when we look at Latino populations, we see that early on, kind of around June and July, we saw this increase in the disproportionate, or basically the disproportionate impact of cases within this population emerged early on, with this kind of trailing emergence of this disproportionate impact of deaths within this population coming up to the current time period around kind of, and I think this data ends, in September. It doesn't necessarily go to our current time in, doesn't capture October and November. Information on Native American populations also show kind of alarming disparities. First, that the disproportionate burden of cases was actually about the same magnitude as that seen in Black populations, and that the disproportionate impact of death, started, as not as impactful, but increased rapidly to the point where the disproportionate impact of deaths within this population is quickly catching up to the disproportionate impact of cases. Here we can also, for comparative purposes, see that among white populations, those disproportionate impacts are actually less than, so basically death in cases comprise less than the share of the population that you would expect if basically the deaths in cases were randomly distributed in the population. So having this robust data around race ethnicity really allowed us to capture the true magnitude and the alarming magnitude at which Black, Latino, and Native American populations were being disproportionately impacted by both COVID cases and deaths. And in that vein, a rapidly evolving and continually growing body of literature not only moved forward in capturing the magnitude of these disparities, again, over time, as I showed in the previous slides, but also there was an emerging body of literature exploring the driving factors of these disparities, of course, in hopes to find those intervening points in order to reduce disparities. And early on, and the pandemic, there was a lot of rhetoric around, of course, the disproportionate impact of obesity, diabetes, hypertension, and other kind of chronic diseases within Black, Latino, and Native American populations as one of kind of the key factors in shaping the disproportionate, or it was touted to shape both the disproportionate case impact and mortality impact. But if you kind of think about the role of these factors, it's actually that having these factors definitely puts you at higher risk of having a more severe case progression, as well as a higher risk of morbidity and mortality resulting from the COVID-19 disease experience. But there was also a parallel kind of body of work kind of highlighting the fact that there's these social factors, these social determinants that have long been studied in public health that were really shaping actual exposure patterns. So if you think about, the continuum of disease, you aren't at risk of having a severe case of disease if you're not actually exposed to the virus. And so there's also this parallel kind of body of work showing that, are highlighting that Black and Latino and Native American populations that were disproportionately low income, disproportionately living in crowded or intergenerational housing, or disproportionately represented within the population of essential workers, was actually shaping an exposure context or exposure in ecosystem that disproportionately expose these populations to the disease, to the virus, which then, of course, increase their risk of getting the disease and having these adverse sequelae resulting from this disproportionate burden of chronic disease within the population. And so with these two kind of bodies of evidence on the causes or the root causes of racial disparities in COVID-19 and disparities emerging, there's kind of this dual kind of back and forth around, or at least in terms of when I was reading the literature, it seemed that there was this dual back and forth between, do we focus on the individual level chronic disease factors? Do we focus on social context factors? How do we, go between and weigh the impact of these two domains of impact? And of course, I would be remiss if I did not mention that as in the early days of when the pandemic was, or these disparities in COVID-19 were emerging, as there were these calls to increase the robustness of racial ethnic data. This was also at the time where there was, an outbreak of police violence and killing of Black Americans, which, I want to highlight. This is actually a longstanding, what we call endemic or longstanding existing and widespread problem in the US, but an outbreak of this kind of rose to the top or kind of came to a head in late May with the killings of Ahmaud Arbery, George Floyd, and Breonna Taylor. And that really put put a very stark lens to the urgency of addressing both of these pandemics, the fact that there were racial ethnic disparities emerging in COVID-19, while there was still this ongoing racial disparity in how Black and brown populations were treated by, you know, police and how they were policed, really kind of co-highlighted the urgency of addressing both of these, you know, social issues. And in the context of these dual pandemics, looking at these together was really where it kind of uncovered and directly kind of shone a light on the role of structural racism as a root cause of both of these pandemics. And I do want to highlight here this commentary that was published in the New England Journal of Medicine by Dr. Rachel Hardiman, Soul and Breath, that I think does you know, a really excellent job of drawing these connections between the emergence and the ways that the COVID-19 disparity, racial disparities were being being treated, as well as how this was feeding into kind of the activism and the uprisings around racial injustice with regards to these broad race these incidences of police violence within the Black community. And so, again, both of these dual pandemics highlighted structural racism, and I think this is where the kind of straightforward focus on this as a root cause emerged. And before I start talking about how you know, structural racism operates as a foundational cause, especially when we think about how it gets embedded in place, I first want to start with the definition of structural racism, just to make sure, you know, everybody's on the same page. And this is from an article in The Lancet by Zinzi Bailey and colleagues. And they define structural racism as the totality of ways in which societies foster racial discrimination through mutually reinforcing inequitable systems, such as those listed here, that in turn reinforce discriminatory beliefs, values, and distribution of resources. So things I like to highlight that are embedded in this definition is, first, that it's structural racism isn't talking about kind of a amorphous system. It's really talking about the connection across multiple domains of racist practices within these domains, feeding into each other to amplify the kind of overarching context in which Black and brown populations must navigate, and also experience these kind of disproportionate exposure to, you know, lack of access to resources and lack of access to opportunity. And if we take kind of that definition of structural racism and, you know, the multidimensionality nature of it, the kind of reinforcing element of it, and then kind of dig into, okay, so how does that focus as a root cause of these downstream health outcomes? I think one of the foundational frameworks that we use in public health is called fundamental cause theorem, that was put forward by Bruce Link and blank on the name, but Lincoln Phelan back in the 90s, and has evolved since then. And this heuristic from the Bay Area Regional Health Inequities Initiative does a great job of kind of describing how fundamental cause theory operates. And basically, fundamental cause theory posits that there's this continuum of factors that impact these kind of endpoint disease outcomes. So in this case, there's this continuum of factors impacting COVID-19 disease rates that range from downstream, which can be thought of as very close or proximal to the individual, to very upstream, which is thought of as kind of distal from the individual and kind of not within the immediate kind of milieu of the individual, but still shaping the context through which individuals move. And an important and critical piece of fundamental cause theory is that if we just target risk behaviors and outcomes here, that actually won't shift these upstream contexts that are actually the kind of generating processes that are shaping the extent to which, say, populations can engage in health promoting behaviors, the extent to which populations experience stress or lack of material resources that would allow them to prevent disease onset and manage disease onset once it comes, once it emerges, right? So going back to our previous kind of like, is it this individual kind of chronic disease, or is it these more kind of upstream social structural factors? Thinking of fundamental cause theory, this tension really isn't necessarily a duality, but more of a both and kind of context. It's really highlighting the fact that while individual factors may matter, treating them in isolation without kind of addressing these kind of root and foundational contexts that are shaping why these kind of more proximal factors even emerge in the first place, will not actually get at the root cause of disease and health outcomes. And in the context of COVID-19, won't actually get at those root causes of what's driving COVID-19 racial disparities. And so that's kind of the framework which I use when I'm talking about, you know, structural racism as a root cause of COVID-19 disparities. And before we get into some work that we did in Philadelphia, kind of looking at this in a very kind of like a robust way, there's one element of this definition that I want to highlight. And I think it's very relevant for understanding the context of COVID-19 disparities right now. And it's the fact that it's not, you know, structural racism isn't only multidimensional, but it has this reinforcing aspect. So it's not just, you know, racism experienced within the educational domain, racism experienced with, you know, employment and job context, racism experienced in, say, the housing context, but it's that racism in the housing context can feed back into perpetuate racism that's experienced in the education context, that can feed back into racism that's experienced within the employment context. So there's this mutually enforcing quality of the way in which structural racism operates that I think is critical to the application or understanding of the emergence of COVID-19 disparities at the current moment. And to bring this home, again, translating into this interdimensionality and highlighting here on the right, these 4 domains that have arisen as you know, very important for shaping, you know, whether people can, you know, are essential workers, whether they can shelter in place, whether they can social distance. Within the context of COVID-19, Black and Brown populations are more likely to have employment that is low wage and essential, which not only just impacts their ability to, you know, stay at home or socially distance, but also impacts their income and has long impacted their access to quality housing. Quality housing is, or low quality housing is also disproportionately located within neighborhoods that have been historically segregated, meaning that the investment in those neighborhoods of other kind of health supporting resources, such as food, such as access to green space and parks, and such as other services, has also been limited, meaning that they're also exposed to disproportionately deprived or disadvantaged neighborhoods. Building on top of that, disproportionate disadvantage in neighborhoods feeds into how transportation overlays within these neighborhoods. The way in which transportation networks within these neighborhoods are often fragmented, meaning that if individuals in these populations are needing to get to jobs, essential jobs that are not located within their neighborhoods, so they're actually needing to take, say, 1 or 2 or multiple forms of public transit. And as you can see, as kind of populations move through this loop of racial inequity, it actually creates a vicious cycle of increased risk of exposure to COVID-19 or exposure to SARS-CoV-2 virus, which disproportionately increases the risk of COVID-19. So it's actually this interconnectedness that I think is a big role and a big driving factor for the engine that keeps perpetuating racial disparities in COVID-19. A final piece is that not only is there's this vicious cycle going around these domains of structural racism, but that there's also a legacy of racial residential segregation. That means that the experience of these multiple domains of structural racism are co-located within neighborhoods that have been historically divested in and basically excluded from access to opportunity because of historical segregation. And here I have a map of, this is the 1937 Homeowners Loan Corporation map for Philadelphia, Pennsylvania. And it shows that the red areas and yellow areas were basically, in terms of the federal government, thinking of investing in housing, investing in, creating a economically robust neighborhood through, housing markets. Those neighborhoods that were red and yellow were deemed to be either poor or hazardous, even neighborhoods to invest in, whereas the neighborhoods that are blue and green were deemed to be, positive and robust neighborhoods to invest in. And a key piece of how these maps were designed was not only were they kind of evaluated based off of, the regular kind of economic indicators that you would think, so say maybe household income of people living in that neighborhood, the property values of the housing or residential structures in that, or real estate structures within that neighborhood, but race and immigration status played an explicit role in how these neighborhoods were categorized. So these red neighborhoods were neighborhoods that, regardless of whether, on other indicators of economic robustness, they may have scored high. If they were Black neighborhoods, they were automatically ranked as hazardous investments. And so this foundational kind of segregation that happened on these maps, and these maps were developed for a number of cities across the US, this drove decades of investment or divestment from these neighborhoods, which again, as divestment continued to accumulate, that's where you see these accumulation of, poor housing stock, neighborhoods that don't have goods and services, neighborhoods that have exposure to fragmented transportation networks, and those neighborhoods also are the ones that are disproportionately Black and brown. And so that's really how structural racism becomes embedded in place and be informed by kind of this both empirical and theoretical, reasoning for why, how structural racism becomes embedded in place. Some colleagues and I over here at Drexel and at the Urban Health Collaborative started to look at this in the current moment for COVID-19 disparities in Philadelphia. So here, this is information from a brief that I'm happy to send around going forward. That I did with Dr. Cheryl Barber and Dr. Lonnie Tabb, who are in the Epi department here at Drexel, that explicitly created a indicator of racial segregation for current day racial segregation in Philadelphia. And this is just the proportion of the Black population within a particular neighborhood, which these are zip codes, that would need to move in order to ensure that neighborhood was kind of racially basically racially integrated, right? And the darker colors mean that there's more racial residential segregation, and the lighter colors mean that there's less racial residential segregation. And while there's some variation from the map that you saw earlier, you can still see that these areas of West Philadelphia and some of these areas in North Philadelphia are those areas that are still experiencing pretty consistent and stark racial residential segregation. We then, again, going along this kind of the theoretical pathway of racial residential segregation operates by consolidating structural susceptibility or structural inequities in one place. We also mapped a multidimensional indicator of structural susceptibility, which again hits those domains not only that show up in that multidimensional heuristic of structural racism that I showed, but also are those indicators that are the driving factors of COVID-19 exposure and COVID-19 risk. And again, it's not complete, there's not complete fidelity, but we can see that there are these darker areas, again, in West Philadelphia overlapping with those areas that are, to this day still segregated, as well as up into North Philadelphia. There's still this kind of, again, structural susceptibility that's reflecting this, again, present day and current day racial segregation. And then to bring it into, again, how does this inform the COVID-19 context? We additionally mapped, and this was as of May 15th, although we're currently updating these numbers, and again, by zip code, the confirmed case rate by zip code. And again, we see similar patterns. Over here in West Philadelphia, we see darker areas where the case rates are high. And again, these are areas that are disproportionately segregated and also predominantly Black, as well as seeing these patches of, again, higher burden of cases, case rates in North Philadelphia. And so for us, this was kind of like how these structural inequities that become embedded in place through processes relating to racial residential segregation impact the current context of how COVID-19 disparities are emerging. And finally, we just to bring it all home, we compared the 5 most segregated zip codes in Philadelphia to the 5 least segregated zip codes in Philadelphia. And again, it reflected what we mostly saw in those descriptive maps. Those highly segregated neighborhoods, again, were predominantly Black compared to less prevalence of Black populations within the less segregated neighborhoods. And again, mostly, but again, there's this one outlier here, mostly having high indicators of structural susceptibility. So having higher levels of adverse outcomes on those indicators on the previous slide compared to positive ones. And of course, that led to kind of across the board higher percent of positive tests, as well as higher case rates per 100,000. So for us, it's really brought home the reality of how structural inequity embedded in place actually is playing into the perpetuation of COVID-19 disparities in Philadelphia. And I know there have been a number of other cities that have also done similar analyses, again, reinforcing the fact that, that racial residential segregation and structural inequities embedded in racially segregated neighborhoods are a driving factor, or this root cause of racial inequities in COVID-19. And one element of this that I think emerged as we were kind of going through this process and looking at kind of this legacy of racial residential segregation and the current kind of organization of structural inequities in the current moment, was that these knowledge of structural factors and how they're organized and embedded in place actually was not new. There were a number of papers, and the paper that outlines this is, of course, listed here at the bottom of the slide, highlighting that previous pandemic modeling kind of experiences based off of influenza actually explicitly not only predicted that racial ethnic disparities would emerge, but that they would emerge informed by the disproportionate exposure of Black and Brown and populations of color to low-wage jobs, as well as their inability to work from home and also take 6 days because of these types of employment. And not only was this kind of predictive in these kind of like simulation models, this is actually empirically confirmed with data from the 2009 H1N1 pandemic. And to take this even further, it wasn't only that this was known and had been confirmed, but it was actually that these knowledge of these structural factors embedded in place driving racial disparities had been an explicit kind of objective of understanding how to engage and intervene on these disparities that they saw would emerge was actually an explicit objective of a 2008 convening of stakeholders by the CDC. Again, this was focused on influenza, but there was actually, based off the acknowledgement of this disproportionate and alarming risk that would impact populations of color, there was an actual intent to design pandemic response paradigms to explicitly acknowledge and respond to this, so that population level pandemic response would actually reduce disease rather than creating these pockets in which disease rates and disease severity remain high. And so I think both understanding, how structural inequities are embedded in place now, as well as understanding it within the current or the historical context of this has been known before, really set forth for me an interesting question about how do we leverage the knowledge of place and race to address disparities in COVID-19? Not only right now, but hopefully a pandemic of this level will not occur in the near future, but knowing that scientists have predicted that increasing kind of pandemics of this magnitude may be on the horizon. How do we leverage this knowledge to make sure that we can act on it rather than, again, being somewhat caught off guard as these, racial disparities emerged in the early days of the pandemic? And I think for the first thing I want to amplify, of course, is so that place-based solutions and community solutions really are kind of the crux of this. One easy step is kind of reinforcing mutual aid networks and building community-led initiatives. And the way that that's looked in Philly is that another project that I'm involved in, the West Philadelphia Promise neighborhood, has created a robust infrastructure for working with neighborhood civic organizations, for working with those on the ground that are connected to the needs of their neighborhoods and community, to amplify, how to get people connected with food, how to get people who may be in essential jobs connected with PPE, how to get people who say need childcare connected with childcare or kind of other solutions for remaining safe while navigating the pandemic. And another initiative around kind of community-led initiatives is that, again, that they're, based off of this information that, structural inequities are embedded in place, and places that are more likely to have higher levels of structural inequity are also those places that have high proportions of Black and brown populations. The Black Doctors COVID-19 Consortium designed a testing and outreach plan that was explicitly based off of this understanding of structural vulnerability. And so they created mobile testing sites that went to those communities so that they, could actually access and leverage testing, would actually know where the cases were kind of condensed, and again, could, either activate or direct resources to those in need based off of, again, place-based structural and equity informed action. A second element of how do we leverage this knowledge of place and race to address disparities goes toward toward a different lens. So, understanding the structure of how structural inequities are embedded and co-located in place, and that also overlaps with the places in which brown and Black populations are located, and understanding that there's these networks embedded in place through which we can understand how to intervene and act on to kind of counteract the co-location of structural inequities. There's also this element of narrative, of mindset that's needed. Again, going back to in the early days of the pandemic, we were so focused on the individual factors that were driving racial disparities in COVID-19, we may have missed really important opportunities to seed and amplify these structure and place-based initiatives that would have had potentially a larger impact on reducing those disparities at the current moment. But these narrative changes and narrative shifts are a key piece of actually shifting that system of how do we, looking forward, respond in other pandemic contexts in which we know that racial and ethnic populations may be disproportionately impacted. And bridging from the work that we did in Philly and with the same collaborators, we actually are now in the process of doing a project specifically around this kind of narrative shift and place-based initiatives, kind of coalescing history, geography, and lived experiences to understand how do we reimagine place-based solutions to the existing racial inequities that are perpetuated during the COVID-19 pandemic. And so I'll wrap up with saying, I think taken together, under this understanding of racial disparities in COVID-19, these lessons can't be kind of used to correct the past, but they can shape what we bring into the future. And I'm always reminded of a concept that I came across early in the pandemic when, again, the racial disparities were just emerging, the data was not great, and there was these calls to have better and more robust data. The author Arundhati Roy was reflecting on this and highlighted this key concept. Given all the disruption that's happened right now, given the kind of laying bare of the unacceptability of our structures to actually support health and well-being among racially and ethnically marginalized populations, we can either use that to focus on, continue to focus on what's wrong and what's not working, or given this disruption, we can actually step through this portal of the pandemic and decide what we take to the other side, decide that we are going to radically act during this moment to leverage what we know and how we act to intervene to not only reduce kind of COVID-19 disparities in the short run, but to ensure that racial disparities in health overall are not continuing to be continually perpetuated along these pathways of structural inequities, and that in the case of if we're ever to encounter another pandemic, these don't become the mechanisms and the foundations, again, across which racial and ethnic inequities in COVID or whatever the next infectious disease is, continue to be perpetuated. So with that, I will stop. I really thank you for your attention, and I'm happy to take questions now. I think there was a chat that I saw that I am navigating, hopefully, to. Oh.
Yes, sorry. Thank you so much. Thank you. That was really great. I just want to remind everyone, if you have questions, please put them in the Q&A, or you can raise your hand if you want to ask it live. And I think we can unmute you so you can ask the question directly yourself. So while we wait for some questions, I Actually, I have one question. Oh, wait, actually, I'll start with Ethan. How do you see these similar inequities in the prison system, especially with regards to the very high case and death rates in prisons and jails?
Yeah, that's a great question and a great kind of, again, kind of this domain. If we're going back to that heuristic of like the structural racism with many spokes across many different domains, definitely kind of embedded with, I would embed it within the law system, but there's a lot of places where it could fall. It's kind of not only the prison system, but kind of this flow of how we understand and interpret justice within racially and ethnically marginalized populations compared to the overall population. So I think there's this one scale of the structural racism that has made it okay to disproportionately please Black and brown neighborhoods, meaning that those individuals are disproportionately represented not only within the justice scale in local county jails, but also within the larger prison system, means that it's along those lines with which racial inequities and whatever kind of how those disease progressions and exposures were going to evolve are also hewn. But also, I think in how that's played into the extent to which, again, prison conditions have for long been completely unacceptable. That's the kind of only way to talk about it in terms of crowding, in terms of kind of the extent to which people are in, again, jails and prisons are all similar but different systems, but are in jails without necessarily explicit charges brought, who are in jails because they can't reach bail. The fact that that's coalescing a condition in which there's just by nature of it crowding and a distinct inability to socially isolate, along with this intersecting of essential workers within the kind of kind of prison guards and wardens moving in and out of the population, means that, we're exposing Black and brown populations within the prison system who don't have agency to socially isolate, to actually have agency to protect themselves against disease, to these disproportionate rates of COVID-19, and then not having a robust, health system that actually addresses that disease. I think that's a critical thing to highlight. And in that vein, and I'm happy to share this in the chat, there's a recent story in Vox about a team that actually had created used agent-based modeling, which is a type of system science methodology, to create kind of a synthetic city to explicitly understand how police interactions, as well as prison populations and kind of the flow between prison populations and these communities who are, again, historically segregated, was actually one of the driving factors, or operates as a driving factor of both racial disparities in COVID right now, cases and deaths, but also just the rates of COVID disease and the burden of disease and death within the overarching population. So I think that I'm happy to share that, but I think that gives a tangible understanding of, how, the prison system and also the inequitable justice system plays a role in, amplifying these racial inequities.
Great, thanks. Yeah, I would, if you could share that paper, maybe at the end, and also the paper that you mentioned, your own paper that you mentioned in the talk.
Absolutely,
would be really interesting resources. Another question is, how do you feel about the breakdown of vaccine efficacy data by race in the recent Pfizer and Moderna announcements? It struck me as potentially playing into a harmful biological essentialist idea of race, given that for-profit vaccine distribution under capitalism is inherently racist, especially at a global level.
I think that's bringing up a lot of important things to consider when we're looking at any race data, but especially kind of this intersection of race data in the context of, any kind of medical efficacy, right? Because I think race often, if we are not cognizant of what we mean by race ethnicity, can subsume a lot of different meaning and a lot of different intent, right? When I'm talking about race and talking about how it plays as a proxy for understanding disproportionate exposure to structural inequities, historical marginalization, and systems of racism that may operate differently in terms of what we might term vaccine efficacy than if I'm assuming there's actually a biological difference in how vaccines are more or less efficacious by race. And if it's kind of the latter, I think that is very, very much of concern because there's a long history, or I will say a long history, but one that has been strategically kind of siloed, I think, in some ways, of understanding that race is a social construct. So if we're really going to understand biological differences or kind of leveraging kind of biological or genetic differences in vaccine efficacy becomes very dicey if that's the leg you're trying to stand on. And so I think in one of the organizations that I kind of mentioned early on, Data for Black Lives, has a very strong platform around being very transparent around how to use race ethnicity data, again, not to amplify these misconceptions about race as a essential or biological imperative, but to understand it from a social construct. And I do think that, and maybe it's not vaccine efficacy, but impact in terms of how to distribute the vaccine, in terms of penetration of vaccines within communities. I do think we need to understand, processes of historical marginalization, which also rightfully have hewn legacies of mistrust of Black and Brown populations of the medical system. And so if we're thinking of race in terms of that kind of paradigm, I think that's reasonable, but again, of course, needs to be done with explicit caveats about assumptions. But breaking down numbers by race needs to be done with much care, because it does run the high risk of perpetuating very harmful notions of biological essentialism that can impede the ability for any vaccine to actually be implemented right in the real world. So I think you're on mute.
Sorry. Anyway, yes, thank you. So another question. Biden recently announced his pandemic response team. Do you have one or two top actions you hope they will take to address these issues? And I just want to add on my question here, because it's kind of related, which is generally how, sort of really into your last slide, like sort of how we step through this door, like how do you see federal or local policies playing a role, and what kind of policies do you think would have an impact?
Right. Well, I think one of the and this goes back to when I was, looking at the literature saying, is this a new thing? Are we newly understanding structural racism or, structural inequities in terms of their place-based distribution as a driving factor of racial inequities? And, resoundingly finding that that's not the case. I think the biggest thing that I think whoever is the COVID kind of task force lead in the Biden administration, and also in terms of local governments, should do is to actually leverage kind of the understanding of structural susceptibility to drive risk, to drive the distribution of resources, both testing resources, to drive whatever kind of infrastructure that's needed in order to ensure that those populations are, those populations are actually kind of the risk in those populations are addressed at the level that it occurs, right? I think, it's hard to recover, now, because it's kind of one of those things that should have been done in the early stages of the pandemic. And it's kind of like this system and accumulating thing. But I know the Center for Othering and Belonging has long kind of articulated, and I think there's some talks about this that happened early in the pandemic by some of the affiliates of that center. They were talking about a concept called targeted universalism, where it's you really, in order to have a universally positive impact on these society level kind of things, we have to acknowledge that there may be targeted intervention needed in order to ensure that those most at just structural risk are actually getting the resources that they need to operate in ways that are most safe and most protective of them, so that they either don't get the disease, or if they do, they actually get the appropriate and equitable care. in terms of how that translates into local actions, I can say in Philadelphia, I think, our publishing of this brief are kind of amplification of these voices, which has happened in a somewhat informal way, and we're, working to formalize it. I think that's been a huge driving factor in starting to shift policies that actually reflect structural vulnerability rather than just biologic or physiologic vulnerability, or just, the easiest, because I think, the easiest way to get tests out, right? And so I think critically engaging in that will be important for, both, the administration as well as local governments. I also think, and this was one of the things that was highlighted in that piece that, the CDC stakeholder piece that I had mentioned, was that they were very explicit that this needs to be done in collaboration with communities. And so to the extent to which communities can transparently be part of the process going forward, however that may look, I think it's important in not only ensuring that the right targets for the right communities are addressed, but also that they become, again, kind of transform into a sustainable process of change that, again, ensures that there's actual movement toward dismantling these structural inequities rather than, we fixed it as a Band-Aid for the pandemic, but, nothing else happened for broad-based racial disparities in health overall.
Great, yeah. And actually the next question is pretty similar. Could you talk about how changes can be made at local, state, and federal level? Then a second question is, is there a particular place in which you think, which has the most ability to change? Like, is there something that's more fluid at the moment that?
That's an interesting question, because my work, I tend to think in kind of like systems and dependencies. So, picking one always, I'm always reflective of how does changing one, dialing up one move the other in either direction that we want or the direction that we don't want. I think right now, if I, feet held to the fire, had to think about that. Because I guess the thing is, like, at the current moment, we're at a current place in the pandemic where, structural, these structural inequities have not been addressed in a comprehensive way, to where we're almost having to kind of focus on more of these downstream things just to kind of keep up. And so I think, targeting infrastructures that allow people to have financial stability, infrastructures that allow people to stay housed in place, infrastructures that may be able to give people some agency in engaging with, either if their houses are crowded because of housing, instability issues, or if they're intergenerational housing where, those networks may be important, but social distancing may not be, may be a challenge within the current space. I think leveraging those resources are an important first place to start. And I know that Philadelphia has begun to, had a number of housing-based programs and rent assistance programs that I think were really beneficial to advancing that. So it's always hard, because again, it's like housing relates to food, relates to, ability to work. And so it's hard to pick one, but I think that's I'll say top of my mind at the current moment. That's probably the best I can do.
All right, thank you. Yeah, makes a lot of sense. So I have one more question, and again, anyone who's still with us, please put any additional questions in the Q&A, or raise your hand if you want to ask live. I'm curious, what are the main roadblocks or challenges to that either you came across or still exist to getting this robust data that really is representative of all racial groups in the US? I mean, this is a problem across multiple fields, and I'm wondering what particular challenges or even successes maybe that you've had when collecting data.
I think that's an interesting challenge, because at least thinking within kind of like the public health surveillance system, right? It's having, there's multiple moving parts that play into this. None are kind of, the most important of which is, are we actually collecting race in a way that represents people's identity and also kind of these domains of structural marginalization, right? Are we capturing kind of the breadth of that? I think that's very important, and I think that the way in which that's done is, it's a challenge. Again, are we allowing people to self-report race when they're coming in for a test? Are we, self-reporting race when we're coming in for cases? Are people who are then looking at the person ascribing a race or assigning a race to them, right? That's kind of been, and this is kind of, so a lot of my regularly scheduled work, shall I say, is in, birth and adverse pregnancy outcomes. So the same kind of questions come up when you're looking at race ethnicity on electronic health records for maternal health, race ethnicity on the birth certificate, like who is actually reporting race. And so I think, that's an ongoing challenge. But I also think in terms of, and especially in cases of where for Latino and Native American populations and in some respects, different subgroups of Asian ethnicities are disproportionately more likely to fall in other or unknown categories, which means there's actually like a structural underreporting, and which means a structural barrier to actually understanding how inequities are playing out in these populations. But even among kind of Black and Latino populations, because again, there's a lot of error, and especially among Latino populations, there's not kind of a robust kind of understanding of different ethnic and backgrounds, which I think, again, is a challenge for fully understanding this problem. But even in that context, the ability to, well, I'll say this and then I'll say the next thought that I'm having two thoughts at once, but even the ability to collect that needs to be done in a way that, again, as was brought up previously, doesn't, for lack of a better word, re-weaponize the data, right? The way in which that's done needs to be done within systems where it's not just like, okay, we're collecting race, but there's an understanding of why we're collecting race. There's an understanding of how it's going to be used. And so that systems, either whether it's electronic, whether it's paper and all of that, there's just an understanding of the need for that field to be filled in, and also the understanding of what it's used for, I think is imperative for it being collected in a way that doesn't, again, re-weaponize the data. The second thought that I was having is that Data for Black Lives, again, has done a lot of their conferences and a lot of their work, and a lot of the affiliates that are embedded within that network have done a lot of great thinking with communities about how should race ethnicity data be collected? How do you see yourself represented? That could actually be leveraged at this moment. So some of those are the nuances. I think in the current moment for current data, it was just that, if there isn't a race ethnicity field in, say, a test screen, right? You have, age, gender, location, what kind of test it was. But if you don't have an age field in that, or excuse me, a race ethnicity field within that system, it's actually somewhat challenging to actually then shift the system to incorporate that. I do think there, of course, states, of course, that have, bit the bullet and done that, which I think is really great. But I think these are the challenges, again, across not only just the public health sphere, but also kind of thinking about how do we understand race, ethnicity as a construct across, domains and disciplines and areas of sectors and areas of practice, that I think, it's hard, but it also is, imperative to do, again, in order to equitably collect this data.
Yeah, definitely. Very important. Yeah. Thank you so much. I think we're at the end of our time and I don't see any more questions. So yeah, I just want to thank you again so much. It's such a great talk. And yeah, thanks so much for joining us. I'll give you applause ourselves.
And it was an absolute pleasure to be able to talk with you all today. So, and I will send those papers to you, Eliza.
Yeah,
and
you can just email me and I can share them to whoever wants. Great. Thank you so much.
Okay, great. All right. Talk to you all later. Bye.